I'm Alessio Cortellini. I'm a consultant in medical oncology working in Rome at the University Campus Biomedico. My field of interest is immunotherapy, specifically in lung cancer, and I also hold an honorary position at Imperial College London. In terms of liquid biopsy, so I can speak more about lung cancer since this is my field of interest. So liquid biopsy, basically, in layman's word, is a technique. With tissue biopsy, you need to take a piece of the tumor and to assess it from the morphological point of view, from the genomical point of view. You need to trace its DNA and establish when there is any actionable biomarker. Liquid biopsy does something similar through the blood, so it's easier from the point of view of getting the sample, because it's just a drip, it's just a venous sample. You can extract with some very sophisticated technique the tumor-specific DNA or even tumor cells, and you can do some assessment from the point of view of quality. So in terms of whether there's any genes altered that can be used for the clinical decision, but also from the point of view of quantity, because depending on the quantity of DNA coming from the tumor, you can establish whether or not the tumor is growing or the tumor is shrinking. So MRD is an acronym that stands for Minimal Residual Disease. It is done basically through liquid biopsies, and from the quantitative assessment, that's what I was telling you earlier. Basically, when a patient undergoes an ablative treatment, or let's say something that is supposed to cure the disease, like surgery, radiation therapy, or even induction chemotherapy, high-dose chemotherapies, it can be used to assess, beyond normal radiological assessment. Let's suppose you undergo a CT scan, there's no tumor residual nodules anywhere in the body. The minimal residual disease assessment is done again another time with the vein samples, with blood samples, and you can assess whether there are any microscopic residual, looking whether there's an residual ctDNA, tumor circulating DNA, or tumor circulating cells, in order to assess whether what you're seeing with the CT scan is also actually represent what is happening through your blood. Yeah, it depends on the technology. There are several panels available. The implementation in clinical practice is still, underway, because we really need guidance, but it's somehow expensive, depending on your country you are. Sometimes it's upon individuals to pay for it. Sometimes it's reimbursed, depending on the setting you are, on specific disease. There are some recommendations to use it, but I do feel we still need guidance. It's not something that can be universally spread. If I can quote Uncle Ben from Spider-Man, it's a great responsibility with great powers. Come great responsibility. It's a very powerful tool, and I'm sure it's going to be used a lot in the future, but we still need some fine-tuning.